We are now going to discuss paroxysmal nocturnal hemoglobinuria. Paroxysmal nocturnal hemoglobinuria is some sort of intravascular hemolysis. So, in order to understand paroxysmal nocturnal hemoglobinuria, we are going to explain it in a whiteboard first, and then we are going to read it from the text. So, what is paroxysmal nocturnal hemoglobinuria? We need to know that the RBCs and the white blood cells and the platelets are circulating in the plasma. They are very vulnerable to activation and destruction by the complement. So, in order to protect themselves from destruction by the complement, they should have something in their surface membrane that will inhibit activation and destruction by the complement. So they will express some proteins called CD55 and CD59, and the function of these proteins is that they inhibit the activation of that complement and the destruction. But in order for CD55 and CD59 to be expressed on the surface of these RBCs, white blood cells, and platelets, they need something to anchor them to the plasma membrane of these cells. And what is anchoring the CD55 and CD59 to the cell membrane is something called GBI. And this GBI is what is attaching to the cell membrane and attaching also to CD55 and to CD59. What is going on in paroxysmal nocturnal hemoglobinuria is there is acquired mutation in the GBI gene or GBI encoding region. So this GBI is not expressed, and when this GBI is not expressed, no CD55 and there is no CD59 expressed on the surface of the red blood cells or white blood cells or platelets. So this will render these RBCs, white blood cells, platelets susceptible to damage by the complement. So when the complement will see these red blood cells without CD55 and CD59, they will go in steps of activation. So most importantly, two steps of activation are included in the pathway of activation of the complement. So the first one is a C5 pathway, and the next one is a C3 pathway. So we will talk about every one of them separately in order to understand how they are activated. So activation of C5 will lead to production of C5b. C5b will bind C6 and C7 and C8 and C9, and this will form what is called membrane attack complex. This membrane attack complex will dig a hole in the surface of the red blood cells, and this will lead to release of the electrolytes from the interior of the RBCs to the exterior, and hence lysis of the cell. This is the first pathway. C5 will form C5b that binds C6, C7, C8, C9, and this is forming what's called membrane attack complex. And this membrane attack complex will cause release of the electrolytes from the inside of the RBCs to the outside. So, what is the next pathway here? The next pathway here is the C3b pathway. And important to know that C3 will form C3b, and this C3b and this C3b will bind the surface of the RBCs. It automatically binds the surface of the RBCs, and when the RBCs will find its way to the spleen, they will find what's called macrophage. The macrophage will bind to RBCs that is found on their surface C3b. So phagocytosis will occur and hence extravascular hemolysis. So there is two important pathways of the destruction of the white blood cells and red blood cells and platelets. The membrane attack complex, and this is intravascular, and the C3b pathway, which is extravascular. Okay, so is the loss of expression of GBI is sufficient for paroxysmal nocturnal hemoglobinuria to occur? And the answer is no. Interestingly enough, GBI mutation, which inhibits the expression of GBI on the surface, is normally found on in the normal population. So there is something else that should happen in order for paroxysmal nocturnal hemoglobinuria to manifest in these patients. So what is going on here is there will be another thing, and that thing is there should be aplastic anemia concomitant with the GBI mutation in order for paroxysmal nocturnal hemoglobinuria to exist. Let's assume that this is the bone marrow, and the bone marrow we say that it's acquired mutation. So we are expecting that there is normal myeloid stem cells and the abnormal myeloid stem cells that is found or that are found on the bone marrow. This small proportion of the abnormal myeloid stem cells are insufficient for clinically apparent paroxysmal nocturnal hemoglobinuria. In order to be apparent, abnormal response of T cell against the normal myeloid stem cells that are GBI positive should occur. So when the normal myeloid stem cells are knocked out, like here, the abnormal myeloid stem cells will take over the place of the normal myeloid stem cells. So we are expecting the normal the bone marrow like that, saying that 80% of bone marrow are abnormal myeloid stem cells that are GBI negative. So once the GBI negative myeloid stem cells are present excessively in the bone marrow, here they will be produced in the circulation in a large amount of RBCs and white blood cells and platelets that are GBI negative. And these GBI negative are susceptible to destruction by the complement. So now we understand that the hemolysis occurred by the complement system. So what is occurring next is what hemoglobin is going, where hemoglobin is going here. So when the RBCs is lysed, hemoglobin will be released in the circulation. So when hemoglobin is released in the circulation, there is protein called haptoglobin. Haptoglobin normally will rescue or scavenge. It's called scavenger protein because it binds free hemoglobin that is normally and under physiologic process will be released into the system or the circulation. Haptoglobin will bind it and they find their way to the macrophage, and the macrophage will phagocytose the hemoglobin haptoglobin complex and scavenger or rescuing hemoglobin and preventing it from its loss in the urine. So in paroxysmal nocturnal hemoglobinuria, there is excess release of hemoglobin hemoglobin is increased enough, and increased as the haptoglobin will know there will be no haptoglobin to bind this excess hemoglobin. So hemoglobin will find its way into the urine, causing hemoglobinuria. This is the first thing. And the next thing is hemoglobin also will be taken up by the proximal convoluted tubule and will be released in the proximal convoluted tubule and metabolized to hemosiderin. Hemosiderin will be released in the urine, but days after the hemolysis. Why days after the hemolysis? Because the proximal convoluted tubule cells, they have lifespan, and when they are shedded from their basement membrane, hence they will be found in urine, and we will find hemosideruria. So, and the next other manifestations of hemoglobinuria, paroxysmal nocturnal hemoglobinuria, is like any other manifestations of intravascular and extravascular hemolysis. LDH will be increased, AST will be increased, because these are enzymes that are found mainly, or they are found in the RBCs. So AST will be increased, LDH will be increased, haptoglobin will be decreased because it is supersaturated and taken up by the macrophage, and there is hemoglobinuria, and there is a hemosideruria. And like any intravascular hemolysis or extravascular hemolysis, the reticulocyte count will be increased. So with this background, we will go back to our text and start reading it. So, paroxysmal nocturnal hemoglobinuria, RBCs, white blood cells, platelets are susceptible to complement activation and destruction. We already said that. Expression of CD55 and CD59 on the surface inhibits complement activation. We already said that. CD55 and CD59 requires GBI to be expressed on the surface. Acquired mutation in the GBI encoding region leads to loss of expression of CD55 and CD59. Concomitant aplastic anemia is the role. Complement activation leads to formation of C3b and C5b. C5b combines with other complement factors to form membrane attack complex, and C3b opsonizes the cells to be phagocytosed in the RBCs, in the reticuloendothelial cells. So there is here intravascular hemolysis, and there is here extravascular hemolysis. Hemolysis is baseline, nocturnal, and after viral infection, and this requires a little bit of explanation here. So we know that it is baseline, but why it's nocturnal and why it is after viral and bacterial infection? It is nocturnal because when we are sleeping, there is hypoventilation. And when there is hypoventilation, there is increased in CO2 trapping. And when CO2 is trapped, more H or hydrogen ions that are present in the circulation will be trapped also. So this will cause acidotic environment in the blood. And this acidotic environment will help in the activation and destruction by the complement. So this is why it's called nocturnal hemoglobinuria. And sometimes the patients will wake up and will find their urine is dark red because of the hemolysis that occur overnight. But I need to say that this is not the most common presentation. We will discuss that. Soon. So, and after viral or bacterial infection, the idea here is viral or bacterial infection will cause an inflammatory response to these pathogens. And inflammatory response to these pathogens mean that more complement will be activated. And when complement is activated, some of these complements will find their way to the RBCs and white blood cells and platelets. And so they are automatically activated and find their way to the RBCs, white blood cells, and platelets and cause destruction and hemolysis. So this explains why the destruction and hemolysis exacerbated by viral and bacterial infection. And the next thing we need to say that thrombosis and neutropenia also occur, because we say that all cell lines are destroyed. But why thrombosis is occurring? This is weakly understood, but we will say that, or there is some theory that say absence of GBI on the surface of the platelets will make them activated innately and form thrombosis. And the other theory that say that release of prothrombotic agents from the RBCs and white bloods from the RBCs and platelets will cause thrombosis. And thrombosis is most commonly present in the cerebral venous thrombosis and hepatic venous thrombosis. So we will now discuss the clinical picture of paroxysmal nocturnal hemoglobinuria and diagnosis. We will read it because we have explained it already. Most cases present with thrombotic events such as hepatic vein thrombosis causing abdominal pain and new onset ascites, and this mainly is the first manifestation that will lead to attention that there is something wrong in the coagulation profile of this patient, and we will draw a CBC for this patient and we will find anemia. Cerebral venous thrombosis causing headache and altered mental status. Abnormal urine appearance in the morning occur but not the most common presentation, we already said that. Lab finding include normocytic anemia because it's intravascular and extravascular hemolysis. And we need to say that it may be macrocytic anemia if reticulocyte count is already very, very increased. Or it may be microcytic anemia if the loss of hemoglobin in the urine exceeded the reservoir of the iron in the human. So it may be normocytic, it may be microcytic, or it may be macrocytic. And increased reticulocyte count, we already say that because it is a hemolytic anemia, elevated LDH, AST, NAST, and decreased hepatoglobin and pancytopenia. And we already explained why there is pancytopenia, because there is concomitant aplastic anemia. Hemoglobin is secreted in urine, causing hemoglobinuria and taken up by proximal convoluted tubule cells, causing hemosideruria. Serial urine analysis is required to detect hemoglobinuria because there may be, after one urine analysis episode, we cannot find that hemoglobin in the urine because it is paroxysmal, or it may be nocturnal, or it may be activated by viral or bacterial infection. So there may be sometimes we will not find hemoglobin in the urine. So we need serial urine culture. We will need serial urine analysis in order to detect hemoglobinuria. The definitive diagnosis is a acidified glycerolysis test and flow cytometry. The idea here is when we cause acidosis in the acidified serum glycerolysis test, we will make an acidotic environment, and this acidotic environment will activate the complement and causes hemolysis. The next idea here of flow cytometry, it detects CD55 and CD59. So absence of CD55 and CD59 on the surface of the white blood cells and red blood cells and platelets will conclude the diagnosis of the paroxysmal nocturnal hemoglobinuria. So what is the treatment of paroxysmal nocturnal hemoglobinuria? Eculizumab is a monoclonal antibody that targets C5, so inhibiting the MAG pathway. So inhibition of the membrane attack complex pathway will not prevent hemolysis, but it will decrease hemolysis. Why? Because the C3 pathway is still working. Because we said there is two pathways for activation of the complement, the C3p pathway and the C5p pathway. So it decreases the need for transfusion but does not eliminate the need for it because the C3p pathway is already activated.